Welcome to the Empower Physical Therapy video series, where we will be bringing you cutting-edge physicians, dietitians, performance coaches, and more.
Stay tuned to learn the latest advancements in pain relief, surgery, and wellness. My name is Julie Butel.
And I'm Matt Tim.
And we're the owners of Empower Physical Therapy.
So Dr. Moore, you completed your physical medicine and rehabilitation and sports medicine residency and fellowship at Mayo. Can you tell the community what that means and how you became interested in that area of practice?
Yeah, so physical medicine and rehab is also abbreviated to PMR. We're also called physiatrists or rehab doctors. It's a relatively small field that most people haven't heard of, but essentially what it is it's a field where we optimize conservative management to improve your function, with that function being impaired for any number of reasons. My specific kind of niche within PMR is musculoskeletal conditions, pathologies, diseases. And so I help to manage and optimize pain and function related to muscle issues, tendon issues, ligament issues, things like that. And so PMR doctors, I kind of think of us as the experts in non-operative management for musculoskeletal conditions, whereas orthopedic surgeons are the experts in operative management for musculoskeletal conditions. I did my PMR residency because I really wanted that background in musculoskeletal medicine and that kind of broad experience. And then I went on and did a sports medicine fellowship at Mayo. And that helped me gain even more specific insight into specific disease pathologies and gave me much more specialized training in musculoskeletal ultrasound and advanced ultrasound guided technologies, procedures, things like that.
Onto that?
That's a good question. Musculoskeletal ultrasound can be helpful for a lot of different reasons. One reason is you can guide injections. Musculoskeletal injections are very, very common, and the most common way to do that across America is what's called palpation-guided injections, where the physician presses on an area, says, all right, I think this is where I'm wanting to go. The tendon or joint or whatnot is deep in this area, and I'm going to put the needle there and assume that I get it in the right spot. And that's the most common way people do injections. There's nothing wrong with that technique at all. I'm a huge fan of guided injections, particularly ultrasound-guided injections, because I'm looking at the structure with ultrasound and I'm guiding the needle to that structure with ultrasound. And I definitively see the needle tip in the area that I'm wanting it, whether that be a bursa, into the joint space, other regions, and then I can see the injectate fill that area. And so it's helpful for a couple of reasons in my mind. One, it increases the accuracy of the injection. And if you look in the literature, palpation-guided injections range anywhere from AC joint injections being 40% of the time accurate palpation guided versus if you're doing it with ultrasound, 99% accurate.
Wow. So a big difference.
Yep. To knee injections, which are probably the most common thing that we inject in the musculoskeletal world, palpation guided injections can be around 70% accurate versus again 95, 99% plus. And if it's not accurate, you kind of have the feeling that you missed something in real time. Mm-hmm. And so one, there's the improved accuracy, and the hope is that if you're getting it where you're intending it to go, right, it's going to work better. Two, I'm able to see all the nearby nerves, vessels, things that I'm trying not to hit, and so I can avoid those things. Three, I'm able to use much smaller needles because I don't need to rely on the feel of the needle and the tissue, and so generally patients tend to tolerate that better.
Okay, so that did the medicine actually go where it?
That is a very good point. So when you do an injection, there's kind of there's three outcomes. One, you get it in the spot that you're intending it to be and you have really good pain relief and we say, yep, that confirms the diagnosis. Two, You get it in the spot that you're intending it to be, and for whatever reason, the injection just never was going to be helpful. When you're doing palpation guided injections, you don't have that increased level of confidence that, yep, 100%, I got it where I wanted it to go. Whereas with ultrasound, you say, nope, I can look at the picture I took, the needle was in the joint, I injected it in that area, and so the destiny of the injection, just it was never going to be helpful.
Not right.
Yep.
So
Exactly.
Okay.
Sometimes things aren't just as simple as there's one diagnosis going on. There could be other components of things going on. And so sometimes we'll do what's called a diagnostic injection, where you just inject numbing medication that lasts for several hours. You inject that into a joint or a bursa or something like that and say, all right, during those hours when the numbing medication's there, is your pain better? If it is, yep, we've got the diagnosis. If it's not, maybe we should take a second look at things. Maybe we need to investigate other areas.
that would be very helpful. Okay.
So in addition to using ultrasound for injections, I know you can also use it for diagnostics as well. Can you explain when you would choose to use ultrasound versus MRI and what the pros and cons are of using one versus the other?
Yeah. With musculoskeletal ultrasound, there's diagnostic ultrasound, meaning I'm looking at that structure, I'm evaluating the integrity of the structure, if there's abnormality, if there's pathology, and then you can use ultrasound to guide procedures, whether that be a simple injection or kind of a fancier, higher level procedure. And so using it for diagnostics is helpful in several areas. Certain times ultrasound is better than MRI for certain structures. Certain times it's complementary and you can get more or different information than MRI. And other times MRI is going to be more helpful. In general, ultrasound gives you really good resolution of superficial structures, of superficial nerves, tendons, muscle. It can't see past bone or into the joint. And so if you need kind of a complete picture of the joint, MRI is going to be the best option for that. Ultrasound, you have a probe and you're looking at whatever is underneath the probe, and you only see a credit card thin slice of whatever you're looking at. And so it's helpful if you kind of have a specific area where you think the pathology is going on, but if it's more diffuse, kind of entire hip region pain, an MRI might be more helpful because it gives you a larger field of view. Ultrasound's nice because it really doesn't have any side effects or risks. There's no radiation involved. I'm not injecting contrast or anything like that. MRI doesn't have radiation involved either. The other nice thing about ultrasound is I can do that in the office. You don't have to go to kind of a giant diagnostic center. It's generally more affordable than an MRI. And so all those things are things that I kind of consider as I'm evaluating a patient to say, all right, should we get an MRI? Should we do an ultrasound? Should we get the MRI and do a follow-up ultrasound or whatnot?
So Dr. Moore, Julie mentioned that you came from Mayo Clinic and you're bringing some new procedures to the Kansas City area. Can you elaborate on the new procedures that you're doing that nobody else in Kansas City is doing, and who may benefit from that?
Yes, so I'm doing a lot of procedures for tendinopathy, things like tennis elbow, golfer's elbow, Achilles tendonitis, things that are for refractory cases of tendinopathy where you've done the typical management, rest, physical therapy, what have you, but still having symptoms. And so there's procedures that can be done like ultrasound guided tenotomy with or without platelet-rich plasma, or 10X procedures. Good question. So the majority of tendinopathies are non-surgical.
Okay.
And what a tendinopathy is, everyone used to call them tendinitis. Itis means inflammation. Most of the time people are coming in with months or years even of pain, and so it's certainly not kind of an acute inflammatory issue, but it's a chronic wear and tear condition at the point that we see them. And so most of the time, the tendon, which should be like a nice normal looking rope that is kind of uniform in thickness and fibrillar appearance, becomes thick and disorganized. And surgery itself isn't going to change any of that unless it's torn off from the attachment, in which case 100% you need surgery, or if there's a really significant, almost full thickness tear of the tendon. Yeah, so muscle turns into tendon, and then the tendon attaches to the bone. And so again, you can think of the tendon like a rope because it's connecting the muscle to the bone. And for whatever reason with tendinopathy, the tendon becomes kind of thick, irritated, disorganized. And the mainstay of management is physical therapy, which is why I'm so glad to have you guys here in town and to welcome me here. And in refractory cases where you're just not able to improve things with physical therapy, there are things that I can do that can help improve them further. And so they're minimally invasive, most of them, meaning I'm able to do them in the office or kind of an outpatient procedural clinic with at most just kind of a stab incision where you don't need any sutures or anything afterwards. And I kind of do different things, whether it be a tenotomy where I'm poking at the tendon with a needle and injecting stuff like platelet-rich plasma, or a 10X procedure, which is a device that actually debrides the tendon to some degree. And then those procedures are to kind of set the stage for the body's typical healing cascade that for whatever reason in that person was halted in kind of a maladaptive healing phase before. And now after that procedure, you go from kind of protecting the area, if it's the elbow, wearing a sling for a week or something like that, and then slowly progressing from there. And so conservative management of tendinopathies is something that I'm increasing access to in town. Management with regenerative medicine techniques, or orthobiologics as is more kind of traditionally called in the field. Things like platelet-rich plasma, bone marrow aspirate concentrate, or the stem cell injection. And those injections can be used for osteoarthritis, tendinopathies, sometimes for nerve damage or nerve injuries as well, and for a host of other conditions. And then one thing that I'm bringing to town is carpal tunnel release with ultrasound guidance. And so carpal tunnel release is for carpal tunnel syndrome, where the nerve that goes into the palm, the median nerve, goes through this tunnel called the carpal tunnel, and it becomes compressed in that tunnel for a variety of reasons. And traditionally, the mainstay of management is, well, you cut the ligament that is the roof of that tunnel to increase the space that that nerve has to kind of live and breathe. And most of the time that's done in the OR, where they cut you open to see everything and cut the ligament, or make small little incisions and put a camera inside the carpal tunnel to look at the ligament as they cut it. But now with ultrasound, you're able to actually do that whole release procedure under ultrasound guidance, so that you're looking at all of the structures in the carpal tunnel, the nerves, the arteries, the tendons. You make a small little stab incision, put this device in the carpal tunnel that can cut the ligament from kind of the inside so that you don't have to make a large incision. Take the device out, and people are having the same improvements in pain and function as with the traditional releases, but they're able to get back to activity much sooner because I made a much smaller incision that I don't have to suture up, and thus you're able to use your hands immediately after.
We have so many. No, there's never a good time to say,
exactly.
I'm just not going to use my hands for the next couple months. So that's fantastic.
So is that procedure done in the office then as well?
Yeah, you can do it in the office. You can do it in a procedure room in a surgery center. In either case, I do it under local anesthesia. So it's like just long injection that I'm doing on you, meaning you're awake, you're not under general anesthesia, but I'm injecting anesthetic, lidocaine, and you're numb, so it's not painful, but you're awake and cognizant through the whole procedure. And so that's one nice thing. You don't have to be put out. Second nice thing is I don't have to suture you up after, so you're able to kind of get back to full activity much sooner. If you look at the literature, there's kind of hundreds of case series and case reports, and most people are back to full activity within 3 days, and that's even heavy manual laborers.
That's fantastic.
How does that compare to a normal carpal tunnel surgery?
So it depends on that specific surgeon's kind of post-procedure recommendations, but normally for an open release, which is kind of the initial procedure that was invented, it's months of restrictions. And for the currently most minimally invasive surgical release, which is an endoscopic release, it's usually weeks of restrictions, where usually for the first couple weeks there's a 5-pound lifting restriction, and then for another couple weeks there's a 10-pound lifting restriction, and slowly getting back to things. And so with the carpal tunnel release with ultrasound guidance, you kind of use your hand as tolerated, take it easy for the first couple days, but then there's no specific restrictions as you would with surgery.
Wow, you can get your hand wet, you can lift things, you can...
Yep, you can get the hand wet, you just can't submerge it in like a hot tub or dirty dishwater until the incision heals, but yeah.
Okay, that's wonderful, that's great.
You mentioned already like the tenotomy, the 10X, but there's also PRP and Shockwave. Is there any others that?
Yeah. So when I think about tendinopathies, again, I always kind of go back to that rope analogy where muscle turns into tendon, tendon attaches to the bone. The tendon should be like a nice, normal, healthy rope. And with tendinopathy, for whatever reason, there's chronic wear and tear degeneration. The fibers get disorganized, the tendon gets thick. You might even have some partial thickness tearing. The mainstay of management for tendinopathies is a specific graded physical therapy program. Strengthening the muscle strengthens the muscle tendon connection and kind of strengthens and stimulates those tendon cells to rebuild and regrow. And so in any phase of management for tendinopathy, physical therapy is critical and is the mainstay of management. Sometimes people aren't able to tolerate that because it's too painful, or they've done therapy and they're just not getting better. In those cases, there are some things that we can do for kind of short-term pain relief options, like doing ultrasound-guided steroid injections around that tendon. We do that commonly for like rotator cuff tendinopathy or gluteus medius tendinopathy, which is kind of the side of the hip. In other cases, steroid injections have actually been proven to have worse outcomes in the literature. So for tennis elbow, we generally don't do steroid injections in that area because at 1 year out after steroid injection, people are doing worse than what they were doing a year before when they were in a bad situation and already coming to see you guys. And so sometimes steroid injections can be an option. Again, I always like to use ultrasound to guide that injection so that 1, I know I'm getting it where I want it to be, and 2, you're really able to judge the response of the patient because you know it's confidently there. And so if they got months and months of pain relief, that might be a reason to do it again in the future. If they just got a week of pain relief, well, we're not going to do that again. It's not worth it. And so steroid can be an option in management, but I think of it as a pain Band-Aid to allow you to tolerate therapy better. There's other things you can sprinkle on top of therapy sometimes, things like nitro patches to kind of increase blood flow to the tendon area, certain other soft tissue modalities, certain braces. One thing that you guys have just started here, shockwave therapy, I think is a fantastic option for tendinopathy. It's conservative, non-invasive, really doesn't have any risks or side effects to it. And then if we get someone to a point where they're just still having a lot of pain and dysfunction despite trialing all of those things for months and not having good outcomes, there are the kind of fancier things that I can do. And I call them fancier because it's not just as simple as you coming in and getting the procedure done, but there's a lot of kind of patient buy-in and post-procedure restrictions that aren't as easy as just going in and getting a steroid injection. And so things like the ultrasound-guided tenotomy, which again means I'm poking at the tendon with a needle, injecting it sometimes with platelet-rich plasma, which is where I draw your blood, spin that down to the platelets. Platelets are like bags of growth factor. You inject that into the tendon, and the growth factor can help optimize the healing environment. And then the other procedure is the 10X procedure, which is this kind of souped up needle that actually debrides tissue as you're going through the tendon. And so all of those procedures, while they have good outcomes for refractory tendinopathy, it really takes months to heal after that. And so if someone comes in, they're not feeling great because they're coming in to see me for the first place. I do this procedure to almost cause damage to some degree initially, and so you feel worse for the first couple days to weeks. And then at about 4 to 6 weeks after the procedure is really when you first start to notice, okay, I'm a little better than when I came in the first time, and that continues out to about 3 months, and 3 months is where we judge the efficacy of the procedure. And that timeline is because we're using the patient or your body's own natural ability to heal. And so our bodies don't heal all that quickly, and to really heal, you want the tendon to be kind of healthy and robust, and it takes kind of days for that acute inflammatory injury phase to improve, and then it goes to this proliferative phase where the tendon lays down a bunch of kind of quick building blocks for the tendon, and that lasts weeks, and then you go through this remodeling phase where that quick building block that was laid down gets remodeled to healthy tendon that is kind of that nice normal rope structure that we're talking about before. And so it really takes months after one of those fancy advanced tendon procedures to completely heal.
Of this?
Yeah, so extracorporeal shockwave therapy, I think, is a fantastic, conservative, non-invasive management option in the spectrum of kind of tendinopathy management. And so usually when I have someone in office and I'm diagnosing them with tendinopathy, with tennis elbow, I kind of lay out that the foundation of management is physical therapy. That is always going to be a key, whether we just do that or we sprinkle things on top of that, or you have refractory symptoms and we need to do one of the higher level procedures that I was talking about. You still need to be doing that physical therapy component, and we're not going to get anywhere without it. Shockwave therapy is nice because there's really no side effects or risks with the procedure, meaning if it didn't work, shoot, that's frustrating, but we haven't caused any damage or any harm. It's really well tolerated. And maybe let me back up and kind of go a little bit into what shockwave therapy is. So a shockwave therapy device is a device that is put on a place of tendinosis, tendinopathy, and it sends acoustic shock waves down through the tissue. And as those shock waves propagate through the tissue, the mechanical disruption and forces that cause can help to stimulate the tendon cells or tenocytes to kind of rebuild, reheal. It can change that disorganized rope a structure that I was talking about of tendinopathy into a more reorganized, more normal collagen kind of pattern or fibril organization. And it can do a host of other things. And so how we use it with tendinopathy is really kind of early on in the course if you're interested. Generally, you do about one session a week, and the session takes 10-15 minutes. And you do that for a couple weeks, and if things are improving, that's fantastic. Can sometimes consider more if you're continuing to improve. If things aren't improving, all right, well, we tried that, maybe we should talk about the other options. But, and you guys can speak to this more than I can since you're the ones doing it. When you come in for the shockwave procedure, it's not terribly painful. There might be some mild discomfort, but oftentimes people feel better kind of right away, and that lasts for hours to days. Sometimes people feel better right away, and that is maintained, and we can't really explain it, but that's fantastic. And there's no downtime after the procedure, meaning you're not in a sling for a week and me telling you not to do things, but you're able to go enjoy your life, and you kind of layer it on top of physical therapy. And so when I'm using or kind of explaining to patients about shockwave therapy, I put it on a spectrum of kind of conservative to more invasive on that super conservative end. It's more conservative than me prescribing medication to you because there's no really side effects of the medication or anything like that to consider. When we get into more refractory cases where I'm talking about procedures, now I'm poking things in your body and I'm putting potential risks in that weren't a part of the shockwave therapy. And so that's why I put it on this spectrum that is kind of the most conservative option.
Tolerate your rehabilitation, because with the tendon, if you can't
And one of the main reasons I love shockwave therapy is that it has good basis in the literature. There are studies that show it can be effective. That with physical therapy, as you guys know, there are a lot of soft tissue modalities that can be helpful. In general, things like Graston technique or dried needling or whatnot, and I'm a huge fan of using those. When I think about all the modalities and I kind of consider shockwave therapy as one of those modalities, I really think shockwave therapy has the most robust evidence in the literature. And if you look in the literature, it's not like it's a home run every single time for every single patient. And there's a lot of variability in terms of protocols and whatnot, but how I've used it in the past and how you guys are using it here, I think it's a fantastic option that, again, is non-invasive, conservative. You're not kind of causing any damage or not able to choose any other option after it. And it's a simple thing to try in patients that are just not getting better with physical therapy alone, or to couple with physical therapy right off the bat to really optimize improvement.
Dr. Moore, a lot of our patients that have joint, muscle, or tendon, or a lot of people in the community that do, may have been living with it for a while and just aren't sure what the next step is, or they may not have hope that it can get better. If they are looking to go see a physician, how do they decide if they go see a PM&R doctor or an orthopedic surgeon?
Yeah, that's a good question. And I think it's something that a lot of people wonder, don't know about. And part of it is the terminology is confusing because no one knows what a PMR doctor is. But again, orthopedic surgeons are experts in surgical management for musculoskeletal conditions. And I consider myself a non-operative musculoskeletal doctor, which means I should be the expert in all of the management options outside of surgery, all of the conservative, non-operative management options. The majority of musculoskeletal injuries are non-operative. I am well trained to know times when they should be operative and when I can refer to my surgical colleagues. I'm fortunate at Apex to have fantastic surgical colleagues that ran the gamut of every kind of subspecialty there is with orthopedics. And I'm also very realistic, and if I think surgery is an option but not a necessity, I'll bring that up and say, if you want to talk with a surgeon, I'm more than happy to refer you. But I think for a lot of conditions, starting with a conservative non-operative approach is the standard thing to do. And again, I'm trained in kind of the spectrum of that, from specific physical therapy scripts, so that when they're sent to you guys, you already have kind of the initial diagnosis that I'm thinking of and the specific things that I'm wanting, and you can build off of that, to medications that may be helpful, to simple ultrasound guided injections that may be helpful, to those fancier higher level procedures that we were talking about. I can diagnostically kind of do all the same things as a surgeon in terms of ordering MRIs, CT scans, other things. And again, it's nice, particularly at Apex, where we have such great relationships with everyone, that if there is a case that I'm not sure about, I can discuss that and easily refer any patient to one of the surgeons. I think oftentimes people with musculoskeletal injuries, particularly those that have been going on for a while, just assume that there's not anything to be done because they've rested and they've waited and they've waited, and they think surgery is the option, particularly if you get an MRI where something says there's a tear or whatnot. A lot of times those conditions, things like partial thickness tears of tendons or whatnot, really aren't surgical. Or meniscal tears, I think, is another really good example, where there's a handful of specific meniscal tears that, yep, 100% you should go to surgery. But the majority of meniscal tears, particularly kind of in the 40 to 70-year-old population, where maybe there's some just degenerative fraying of the meniscus and tearing, the surgical outcomes are just as good as the conservative outcomes. And starting with a full kind of court press of those conservative management options before considering surgery in a lot of those cases, I think leads to the best outcomes.
I agree. here and that you're
Thank
available
you.
for the community to,
Yeah.
to see. You know, if your body's in pain, go see someone who is an expert in body pain.
Yeah, yeah. I think that's a fantastic point. Primary care physicians have to know so much about everything. There's no reason why they should know the higher level specifics and stay up to date on the very specific of every kind of musculoskeletal injury and diagnosis. That's why there are subspecialties within medicine. That's why there's urology, gynecology, things like that, so that the primary care doctor doesn't need to know all of that. And so I am the musculoskeletal injury physician, essentially. And I think most of the time people just think of orthopedic surgeons as that, which they are, but they're trained in how to surgically fix those things. And they have training in conservative management, but that is all my training is. And with that, I have the musculoskeletal ultrasound as a tool that I can use. I have all of the injections that come with that. I have all the procedures that come with that. We get so much more training in terms of what physical therapy am I supposed to be prescribing, rather than just a script that says evaluate and treat. No, I want you to do this specific strengthening program working on neuromuscular control of this or that or whatnot. And it, I think, really makes it more of a team effort and approach. I can't treat anyone independently. It's hard for you guys to treat anyone independently. And so having that team approach of primary care is there for kind of the baseline eval and management. If things aren't improving, come see the specialist. And in general, with musculoskeletal conditions, physical therapy is such a key, and being able to have that relationship and discussion so that you're seeing something different than what I said in my note or what I was thinking, you can talk to me and we can have that conversation back and forth of, all right, this seems like it's changing, or maybe I got the diagnosis wrong and we do need to do something sooner than later in terms of getting imaging or different management. And so that's one of the reasons I love my field as much as I do, is it's all about kind of a team-based approach and really optimizing pain and function for the patient. And if that's improving, that's the best result. And I think with my field as well, there's a lot more opportunity for me to educate the patient and to spend time in the clinic doing that. And I think that's so critical to having good outcomes, that the patient understands what's going on and they know, all right, I'm not fragile, I'm not gonna break, I'm not gonna always have pain or whatnot. Why is this going on right now, and what do we need to do to manage that?
Yes. I'm like, did you Google it? And I'm like, no, Dr. Moore sat down and walked me through it. And I'm like, okay, great. So much better than WebMD, you know?
Yeah.
They usually
Hopefully.
get it right when they come
Yeah.
forward. You know, you can sit down and explain, this is what's going on, and that takes so much of the fear away, and really gives people hope, like, oh my gosh, I can actually get better, and taking that fear away, just knowing what's going on, and then the clients knowing that we can communicate is huge, because so many people say, well, why don't my people, you know, why is this doctor not talking to this doctor? And I feel like, you know, there's no communication anymore. There's all these specialties, but no communication. But, you know, between us and between you and the surgeons, like, there's amazing communication. So it is out there. You just have to, again, that's why we're doing these sessions. It's like you just have to find the right team, the right people that are willing to take that time to communicate. So for that, we're very grateful, and we appreciate your time today.
Thank you.
Yeah, I know our patients that we've referred over are just really impressed, because they know we've talked, and they know that you know, you've listened to kind of what they've been doing in physical therapy, and I think just that communication gives them a lot of confidence, because it's not typical of what they get. So.
Thank you so much.
All right, Dr. Moore, where, if patients are looking to schedule an appointment or find out more about you, how can they find you?
Yep, so we have a fantastic website online, apexorthokc.com. Has all the ways to communicate, get a hold of me. You can also call into Apex at 913-642-0200.